Welcome back. This lecture begins the final chapter of the protozoans, which covers the parasites in the phylum Apicomplexa. The phylum, like I said, is Apicomplexa. It's also known by its class, which is Sporozoa. This group consists of blood and tissue parasites, and it's a very diverse group. However, they're grouped together because there is no obvious structures for the purposes of motility. So your method of motility for the following parasites is none, whereas for the amoebas, they moved by pseudopod. Of course, our one ciliate uses cilia, and the flagellates use a flagella. This group doesn't have any means of motility. So these are the ones we will cover: the Plasmodium species, Babesia species, and both of these groups live in RBCs. Then we will cover two that inhabit the intestinal tract: Cryptosporidium parvum and Isospora belli, and then Toxoplasma gondii can inhabit various organs. So starting with Plasmodium. The genus Plasmodium causes malaria with 1 to 2 million deaths per year worldwide. And in the United States, there's about 1,500 people diagnosed and treated every year, mostly travelers. The vector for Plasmodium is the mosquito, specifically the female mosquito of the genus Anopheles. There are over 200 known species of Plasmodium, and only a handful of them cause malaria, with these four being the top ones. So we have Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and Plasmodium falciparum. Of those four, vivax and falciparum make up 95% of the malarial cases. So I did mention the vector, which is the mosquito. So of course, this can be transmitted by the insect bite. However, because it lives in the bloodstream, it can also be transmitted through blood transfusions, sharing needles, and it can also go from mom to baby. So we've sort of saved the best for last as far as life cycles go. This is the most complex life cycle you'll learn of all the parasites we've covered. There are two phases for Plasmodium. There's a sexual reproductive stage and an asexual reproductive stage. So the asexual is called schizogony. The sexual stages of reproduction are called sporogony. In us, in humans, the asexual reproduction phase occurs. So we are technically the intermediate host by definition. There's also two phases in man, an exoerythrocytic phase, which occurs in the liver, and the erythrocytic phase, which of course occurs inside the red blood cells. So let's talk through it. So an infected female mosquito comes along and bites an uninfected human. So when she does this, she's injecting infective sporozoites into man's bloodstream. So that is your infective stage for humans, the sporozoites from the bite of a female Anopheles mosquito. Within about an hour, those sporozoites reach the liver, they get into the liver cells, and so begins the exoerythrocytic phase. And you know your prefix exo means outside, so this is occurring outside the red blood cells. So for malaria, your exoerythrocytic phase occurs in the liver. So we have sporozoites that have entered liver cells, and they go through the following phases. It will mature, or it will transform into a trophozoite inside the liver cells. The trophozoite will then mature into a schizont, and a schizont releases merozoites. So the merozoites then leave the liver cells and they invade the RBCs, and so begins the erythrocytic phase. So remember, this was an asexual reproductive stage. This is schizogony in man. And the patient is usually asymptomatic during this exoerythrocytic phase. Usually only one cycle of merozoite production occurs in the liver, meaning there's only one cycle of this maturation. You don't usually have continual reproduction of the malarial parasite inside the liver cells. However, with two of our species, Ovale and Vivax, patients have known to relapse. So sometimes with these particular species, the plasmodium may live in a dormant state called hypnozoites in the liver cells, which can cause a relapse years later. So if you think of being hypnotized and going to sleep, these hypnozoites, you can imagine, maybe just go to sleep and hang out in the liver cells maybe for years and can cause a relapse years later. But that's usually only for two of our species. So remember, the end of the exoerythrocytic phase was merozoites being released from liver cells. So those merozoites leave the liver cells, they enter the bloodstream, and they invade the RBCs. And then they go through maturation stages in the red cells. So this is the erythrocytic phase in man. Once it invades the RBCs, it feeds on hemoglobin. And this is very important to mention, that people with hemoglobinopathies have an increased resistance to malaria, because if you have a deficiency in, you don't have all this hemoglobin food for the malarial parasite, then it can't survive as well. So people with thalassemias, sickle cell, hemoglobin C, G6PD deficiencies, these patients actually don't get malaria because the parasite can't survive with their hemoglobinopathies. Also worth mentioning is, and you'll talk about this in blood bank, that Plasmodium vivax enters RBCs through the Duffy antigens. And I know this might not make much sense right now, but if you are lacking the Duffy A or Duffy B, or the Duffy A and the Duffy B antigen, then Plasmodium vivax cannot enter the RBCs. So, and this is a common ASCP type certification question, that people who are Duffy A neg, Duffy B neg have an increased resistance to malaria. On the blood smear, you'll start noticing that there's a brown or black pigment called hemozoin that can be seen inside the RBCs. These are iron deposits, and it's also called malarial pigment, and it comes from that incomplete metabolism of the hemoglobin. So let's talk through the maturation inside the RBCs. So remember, we had a merozoite that came from the liver cells, and it has infected an RBC. The first stage inside the RBC is called the immature trophozoite, or the ring form troph. Okay, and I also want to mention now, we've used this word trophozoite before with previous parasites. Remember, we had cysts and trophs for a lot of our amoebas and the flagellates and our ciliate. And that was the feeding stage. Remember, it was the motile feeding stage for those parasites. This term is not to be, it doesn't mean the same thing here. Remember, malaria has no means of motility, and it doesn't look anything like the trophs we've seen before, obviously. So keep these two trophs completely separate. This looks like a ring, obviously, with a little dot. This is your chromatin mass, and this is a very small ring of cytoplasm that has a vacuole in the middle. So this is your earliest stage. It's called the ring-formed troph. As the trophozoite matures, that vacuole disappears and we get more cytoplasm, but still have our red or purple chromatin dot. So here's your mature troph again, and the appearance of pigment granules. As the parasite continues to mature, it transforms into the immature schizont, where we get splitting of the chromatin mass, so we get multiple chromatin masses here, and again the cytoplasm is still growing. The mature schizont consists of individual merozoites, in which each chromatin mass is surrounded by its own individual cytoplasm. So this is your most mature stage in the erythrocytic phase. It's the mature schizont, which contains individual merozoites. When the RBC ruptures, these individual merozoites can have one of three pathways. It could develop into a macrogametocyte, which is the female form. It could develop into a microgametocyte, which is the male form, or the merozoites can go infect more RBCs and start the erythrocytic phase all over again. It could go from immature troph to mature troph, immature schizont to mature schizont, and release more merozoites. So, but remember, in man, the macrogametocyte and the microgametocyte do not meet up and result in sexual reproduction. That only occurs in the mosquitoes. So if it matures into a male or female form, that's sort of a dead-end road inside man. In order for the parasite to continue, another mosquito needs to come along, or the merozoites keep undergoing schizogony inside the RBCs. So the gametocytes are the male and female forms, so specifically microgametocyte for the male and macrogametocyte for the female. The macrogametocyte has a more condensed chromatin mass. You'll see how the microgametocyte is very loosely organized. And also the cytoplasm, the border of the cytoplasm looks more organized as well, where this is more rough. And the chromatin dot tends to be off-centered, whereas this sometimes is more centered. To continue on with the life cycle, another mosquito needs to come along and bite the infected human and ingest those gametocytes, the macro and the microgametocytes that would be in the bloodstream. In the gut of the mosquito, the gametocytes undergo sporogeny and they form a zygote. The zygote matures and becomes an ookinete. The ookinete penetrates the stomach wall of the mosquito and insists to form an oocyst. Inside the oocyst, up to 10,000 sporozoites develop. The sporozoites are released from the oocyst. They get into the body cavity, migrate to the salivary glands, and this is what gets injected into the next human when the mosquito takes her blood meal. So those sporozoites are infective for man. They are inside the salivary glands, of the female Anopheles mosquito. What is infective for the mosquito? It is the microgametocyte and macrogametocyte. So let's talk through this picture again. Here's a mosquito coming along, and she's ingesting macrogametocytes and microgametocytes from the human she just bit. Those will undergo sporogeny and form a zygote. The zygote matures into an ookinete, which matures into an oocyst, which releases sporozoites, which migrate to the mosquito's salivary glands. She injects the sporozoites into the next human. Those sporozoites go to the liver, beginning the exoerythrocytic cycle. The sporozoites undergo schizogony. They go through troph, schizont, releasing merozoites. The merozoites go into the bloodstream, and so begins the erythrocytic cycle. Inside the RBCs, it goes through immature early trophozoite to mature trophozoite, immature schizont into mature schizont, which releases merozoites. Merozoites can do one of three things: mature into a male or female form, or it can go invade more RBCs and go through troph, schizont, releasing merozoites again. So the erythrocytic cycle can continue on indefinitely without treatment, but there's usually only one cycle of the exoerythrocytic phase unless there's hypnozoites involved, which would cause a relapse years later. And here's a fairly old picture from the CDC, but I'm sure it still applies. You get the idea. Malaria transmission occurs mostly in Africa and some other countries. We really don't see it. It's not endemic here. We do see it here, absolutely, but it's mostly from travelers. So, diagnosing malaria. Number one question will be travel history. The next major thing are the symptoms, which is clumped together and called a paroxysm. So a paroxysm is a very defined cycle of symptoms that occurs at specific intervals, and it's always in the same order. This is the chief symptom involved with malaria. So the paroxysm usually starts with a headache, bone pain, just feeling kind of icky and weak, nausea, flu-like. Then there is violently shaking chills, and this can last from 10 minutes to up to an hour. Imagine having rigor, that shaking for an hour. That's pretty intense. Then there's a fever, and this can last for 2 to 6 hours usually, but it can last as long as 20 hours. Then the fever breaks, the patient has profuse sweating, just drenched in sweat, and then they are extremely exhausted and sleepy. So that's your paroxysm. That is your achiness, your flu-like achiness, chills, fever, sweating, exhaustion. So it repeats itself at regular intervals depending on the species involved. It is linked to the rupture of RBCs and release of the merozoites. So what they think is it's like your body's allergic reaction to those red cells rupturing and those merozoites being released. And not only are the merozoites being released, but also toxic waste byproducts into the bloodstream. So that's what's causing these symptoms. So how do we diagnose it in the lab? The gold standard way to diagnose malaria is using the Giemsa stain on thick and thin smears of capillary puncture, doing capillary punctures on the patient. That's another common certification type question. We do the thick smears so that it's more, that's like the screening step. Because of course with the thick smear you get to see lots of RBCs in a smaller volume. But in a thick smear, the red cells are destroyed and it does leave only the parasites, but you can't really speciate it. You can't really get a really good look at the parasites, but it's good for screening. So then you go to the thin smear to identify the species and really get a good look at those life cycle stages. The right stain will work also, but the Giemsa stain's your gold standard. So I mentioned we ideally are doing it on capillary blood. And here's a picture. You shouldn't be able to read through thick blood smears, and you should be able to read through a thin film. The timing is important. You want to do it in between paroxysms because that's when the most parasites should be in the bloodstream. And you don't just with it, like with any other parasite testing, you don't just do one. You do several of these over 2 to 3 days.